please help spread the message of Frequency Specific Microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about Frequency Specific Microcurrent.
We have a lot to talk about today.
You start.
Okay. What I have noticed, the amount of people, clients, patients, other healthcare practitioners that say, how do you know that? And to which I'm like, how does somebody not know that? And let me unpack that a little bit more. I think because of what we get, the tool that we have, the tool that we talk about every single podcast that we have in our tool belt, because it, and I typically use the words forces, you'll say enables or allows, but I do feel FSM has forced me to research, read, and learn about body parts and conditions I never knew existed.
Yes. Oh, yeah. I did. Exactly.
And to respect those tissues in a different way, because now I don't just simply know that they exist, but I think about their fibrous makeup, their cartilaginous makeup, their direction of fibers, what their neighbors are, what's attaching to it.
And how they're motivated, what they do, how they function, how they're innervated, what is their blood supply, how are they affected by compression, wear and tear, inflammation.
Get out of my head for just 2 seconds, because that is absolutely, those last 3 things are what I wanted to talk about.
That's how you and I roll. You're always in my head. It's a wonderful thing.
But in the best possible way, I'm hoping.
Exactly.
So let me give you a scenario.
Okay.
Ironman, not just triathlete, but Ironman. Multiple Ironmans. Decided to complete 2 Ironmans in 3 weeks.
Okay, I don't have a frequency for that. There's no anti-dopamine overdose thing, but okay.
But I love this person. I love this person. I've been working with this person for years. I love that they use FSM religiously, that they believe in it, that they know that it helps. But 2 Ironmans in 3 weeks is a lot.
It is a lot. It doesn't give you much recovery time.
It doesn't. But we can do great things. After seeing this person in between the first and the second, they have bilateral, lateral knee pain.
Okay.
That has been assessed and treated as IT band syndrome. So now I can say that's a good face. And I say, I get it. I get it why a massage therapist or a trainer would throw that out, because that's all that they know and that's all that they maybe can treat. But when you just complete an Ironman that is swimming, and running, your menisci.
Thank you. It's not the IT band.
Like flattened hamburgers.
They're going to be a little bit overworked and underpaid, and they're going to have an opinion about that. And lateral knee pain so far is either torn and broken in the ligaments if you get hit from the side and you're playing soccer, or it's the meniscus, or it's torn and broken in the connective tissue where the IT band and the pes anserine is medial, where the IT band comes around.
Sure.
But it's a meniscus and the bursa.
Yep.
Okay.
So massaging it, not going to help. Using the Theragun or the percussive instruments, going to make it worse. It's inflamed, it's torn, it does more percussive.
Why do they think that percussion is going to help?
I don't know.
Okay, good. I'm right there with you. Thank you.
So because this is an elite athlete, because we are under pressure, we have another Ironman coming up. It's not outside.
Oh, so he's in between the two?
Yes.
Okay.
So I get to be the fix-it guy. and help really dial in absolutely everything that could be torn and broken, or our new favorite word, repair and heal. We're going to repair and heal all the tissues and get that person ready for the next one.
Actually, I'd spend a whole hour on repair and heal the meniscus.
Yes.
An hour, 4 machines on one knee is not excessive.
And they have a custom care.
Torn and broken, it's 77,
Yep.
and 40 and 195.
Mhm.
And the other possibility, especially since it's not really worth it to do an MRI, I'd head for inflammation in the periosteum, but also inflammation in 59 and 39, the bone.
Yeah.
There's no way to run
A full marathon.
a full marathon. There's no way to run a full marathon and then follow that with the other things.
No, the marathon is at the end after biking 100 and some odd miles, and after swimming is the first. So swim, bike, run.
Yeah. And it's so the meniscus is going to get hit in the biking and swimming. And then by the time you get to running, the meniscus has already been abused. But the running, you got bone bruises. So you've got 59, 39, you've got the cartilage under the meniscus. And did I miss anything? Am I still in your brain?
You're still in my brain. But
Okay.
how I love to categorize the B channels first. That's easier for me to make my list. I know exactly what tissues are affected. And then I start going back to the A. Yeah. Torn and broken, inflamed. You don't need a PhD to figure out that those are going to be your big ones. But then you start to expand and start thinking a little bit more about what other A channels could be affected. So as I was digging and looking at netters, I was looking at the menisci, and you've got your outer portion, you have the posterior horns, you've got the anterior horns. And then when you start Googling the difference of makeup between the two horns, that the anterior and posterior horns of the menisci, those little cups, the divots, have a very rich blood supply. And you don't think of the menisci as bleeding. You think of vascular tissue, muscle belly as bleeding, but there's bleeding in it.
Very good, especially with running.
Yes. So with the micro trauma, so you think of macro trauma, micro trauma. So I do use trauma. I do use 94 and 294 quite a bit in my post-exertional recipes, because the torn and broken and the bleeding didn't come from outer space. There is some sort of trauma, and trauma doesn't have to be bad trauma. It's traumatic to the tissue. So I like to use those first. I like to use our basics, 94, 321, and 9 with the bleeding. So those are all the other components. And when you have an athlete that has their own custom care, you can make these programs as long or as short as you want. And something else that I wanted to talk about was, we had an email, and I can't remember if it was a knee or an ankle, but the person was talking, I think it was the high ankle sprain we talked about last week.
Oh, yeah.
About making a program for 3 or 4 hours long. And I don't love that length. I like making shorter programs so it allows somebody to get up, hydrate, have a snack. I guess it depends on your audience. If you know that person is going to run something at night, make it as long as you want.
Yeah, but the 3-hour programs are for bedtime.
But I know a lot of athletes that are like, more is more. And if I should run it 6 hours a day, I will. And that's great. But for the average person, if you tell them, I want you to run this for 6 hours a day, they're going to run it for no hours, because they think, I don't have 6 hours to sit down. But if you have an hour in the morning and an hour in the afternoon and 45 minutes at night, sometimes it's a little bit more digestible for people.
Okay, fair enough.
It's just like back in the day, I'm talking a lot this already, but back in the day when I was learning exercise prescription, we would talk about, you have to know your audience and who you're talking to. If you want somebody to stretch or strengthen or do their exercises 3 times a day, some people you'll have to say, I want you to do it 6 times. because then they'll only do it 3. And some people, you have to say, I want you to do it 1 time, because you'll know they'll do it 5 times. Again, and you're the psychology maestro of the podcast, but athletes tend to overdo things. Triathletes who compete in Ironman competitions and decide to do 2 in 1 month tend to overdo things. Going back to our menisci, a person who does this type of leisure activities, their nervous system knows that pain will not equal stoppage. So the compensations that you see when somebody like this walks into the clinic are staring you in the face with big neon lights. But now is not the time to fix things. So again, you have to be careful. I'm not undoing any compensation when somebody's competing in 2 weeks.
I have a question about that, especially since mechanics is your ballpark.
Yeah.
If I can see it, because the compensations are to protect the injured tissue, but if you fix the injured tissue, because you've got 2 whole weeks, and you can see this guy 3 times a week, and getting him put back together and repaired in 2 weeks is not that hard.
Mm-hmm.
And so then 2-3 days before his next event, that's when you do wipe and load. You've got to tell his hippocampus, it's okay. He's going to be fine. It only hurt for a little while, and now it's all better. See? And then you do 40 and 92 so the sensory motor cortex forgets that everything it thought it knew about how that leg, hip, and foot were supposed to move. Then you do 40 and 84 so the compensations go away. And then you do 81 and 92 and 81 and 84 and get everything moving correctly while you have the guy running in place in your gym. Because if he goes into, at least this is my hit on it, if he goes in to the second Ironman and you have repaired the stuff he busted up in the first one, but you leave the compensations in place as if they're still busted, he's going to bust something totally new.
For sure.
So I would do wipe and load the last visit before he competes. If the competition is Sunday, you see him Friday and fix his brain. Does that work?
It does. And it's all within reason, I guess, is what I'm saying. You're not going to be undoing everything. And when you remove the boulders from the stream, the water flows freely. So I always think about this analogy of this beautifully running stream in paradise, and there's rocks in the stream, and the water meanders around the rocks. But if there's a giant boulder, that's creating a lot more resistance for the water. So your job as a performance therapist, chiropractor, massage therapist, trainer, whatever, is to remove the resistance from the body. So all the compensations that walk in, if you are treating the torn and broken, if you're treating the bleeding, if you're helping with repairing those deep structural pieces of resistance, the muscles will start to fire better because there's typically no pain, right? So if the meniscus isn't creating pain, there's not necessarily going to be a gait discrepancy. Just let me finish.
Okay. You forgot about the hippocampus. The meniscus.
I haven't. I'm getting to it.
Okay.
We're removing the resistance is what I'm getting at. So if the menisci are causing the hamstrings to crank up, which is causing the pelvis to rotate posteriorly, which is causing the psoas on the opposite side to tighten up to try to stabilize, going after the psoas is not going to do anything. So my point of correcting imbalances is when you're treating the cause, all the imbalances, all that, when you start looking upstream, they start to correct themselves, taking out the cause, the causation of the compensation. So that's what I'm saying is you will have some therapists like, we have to fix her hips. No, The menisci are the problem. The hips are going to go back once the meniscus is fixed. And this is what I meant to say by we're not undoing everything in a, oh, we have to fix your shoulder, we have to do this. This is where it's really important to treat the cause.
Yeah,
So
totally.
I've not forgotten about the hippocampus, because 40 and 89, as you are doing these, is crucial. So I'll have it running simultaneously so that there's constant feedback to say, the menisci, we're good. Don't worry about it anymore. Now we're going to move on to this structure. Yes, 3-4 machines during that time with constant feedback.
Works for me.
Yeah. You were going to say something, but hopefully I talked myself out of the hole that I was
You
jumping.
talked yourself out of the hole. I had an entirely different experience this week.
Okay. Let's
I
hear it.
a patient with basically pelvic radiation that sort of fried some lymph nodes. And so she gets lymphedema, and then she'll get cellulitis, which is infectious, not just inflammatory, it's infected. And she goes from cellulitis, gee, that looks red and puffy, to septic in 2 to 3 hours.
Wow.
Now, the medical physician, this goes back to what you were saying and what FSM people do, treat the cause. So the medical physicians that she's seeing say the lymphedema is the cause of the cellulitis. And I looked at her and I said, that actually doesn't make any sense, because lymphatic fluid is sterile. There's no bugs in it. It doesn't get infected from space. There is a reservoir of infection someplace in your body. And because the lymphatic fluid pools in your abdomen where all that radiation was, the bug from wherever it is sits in that pool in your abdomen, and then you get cellulitis and infection. And then somebody, literally, she's got a laundry list of doctors that she sees. Has nobody talked to you about the reservoir of infection? What's that? Do you still have your tonsils? Yeah. Did you have your wisdom teeth out? Yeah. Okay. Wisdom teeth, when they take them out, sometimes they put a filler in there, and that becomes a focus of chronic occult infection. One of her bladder infections before all this started, she had chronic bladder infections, they cultured it. It was beta hemolytic strep in the bladder. Beta hemolytic strep lives in the tonsils. She still has her tonsils. She still has her appendix. Okay, this had nothing to do with FSM. I could treat radiation, I could treat scarring and lymphatics, and everything would soften and the lymph nodes would clear, but it would fill back up again. And she always goes someplace with antibiotics, so I didn't worry about her getting cellulitis. But when they tested your vitamin D levels, let's talk about prevention. So I'm going from this is what FSM can do to the stable state. What is our actual goal? Our actual goal is to fix the patient. So she looked up in her records her vitamin D levels in January of this year, the last time they were tested, were 13. Okay. And then we talked about vitamin C. So let's talk about, you are stuck with lymphedema because the architecture is just permanently altered. I can't fix it. There's just too many surgeries. FSM can help, but it's temporary. You already have gadgets at home. You already have PTs that are working on you. I'm not going to sell you a custom care. That's, if you want to, you can buy one later, but not now. You're going to take 50,000 units of vitamin D 3 times a week for 3 months, and then you're going to test your vitamin D levels. And then you're going to take 50,000 units of vitamin D for another 3 months, and then you're going to test it. And then you're going to slow down to once a week when your vitamin D levels get to 60 or 70. And then you're going to take 5 grams of vitamin C a day. And you're going to ask your doctors to look for the reservoir of infection. She said, I have one doctor that actually listens to me. I said, that's the one you want to talk to. There was another one. She came in with lifelong, she was born with it, atopic dermatitis. She had, so her presenting complaint was eczema. And you could see it on her wrists. They were rough and red. Her eyes were dry. Her skin was dry. Her vagina was dry. Her elbows were like red and scaly and rough. So, dang, girl. So the first day, she's 67 and she's a vegan. Stick out your tongue, deep groove down the middle, bright red. There's no red in your, maybe in those butterflies behind you, there's that red. They were bright red, deep lateral grooves. And I said, and she too has been to multiple doctors. She was on steroids from infancy till she was in her 20s. And then she's been recovering from that. Now that was 40 years ago. So here's her tongue. And this is my other tool. That's, hi, Ellie. This is Dr. Google. So I just Googled B vitamin deficiency and atopic dermatitis, or B vitamin deficiency and eczema. B1, B3, B5, B7. I didn't even know there was a 7. And everybody knows about B12. That's the tongue thing. She may or may not be able to methylate it, but she said, lots of people have looked at my tongue and they've never told me that I was B12 deficient. So we have that one slide in the core, the kind of peripheral neuropathy you can't fix. So the first day, I said, your next stop between here and your hotel is to this Whole Foods or New Seasons or something, and you get B complex, because it's not that leads to dry skin and dry, like every single symptom that she had was B vitamin deficiency and vitamin D. So she's found a good potency and instead is taking 3 drops once a week. She took 6 dropper fulls a day. And by day 3, the lateral grooves on her tongue were gone. Her tongue was normal color. The central groove and the deep grooves were starting to fill in.
Wow.
And there's no thing that FSM could do, because I ran inflammation in the skin, I ran vitality, I ran secretions. And then on the very last day, and I ran the constitutional factors. That was interesting. And then she said, you're born with it, and it's a genetic, and once again, Dr. Google, between the patient and what I looked up, atopic dermatitis, there's a genetic defect in the external barrier that we have that makes our skin smooth. It gives us an oil layer, and the outside part is smooth. There's a gene that just doesn't work right. And I kept feeling like I was missing something. So you know how you look down the paper laminate, and you keep going until you find something that jumps out? There in the solfeggio frequencies were repaired DNA. So the last half hour on the last day that I had her, I did 528 and the skin. This got completely smooth. This went away completely. And her inner arm got 50% better in 30 minutes. And it's so every day we ran leaky gut, every day we ran concussion in Vegas, every day we wrapped from her neck to her hands, because it's the atopic dermatitis is usually in the extremities, the elbows and the wrists and the knees. And with her, it was just all upper extremity. But we get the idea because we can fix so much with FSM. this whole stable state concept that's why those slides are there. And in the course, there's so much, and it's a drive-by, but to think in terms of what makes the system function in such a way that we can help it repair itself. Unless she had adequate amounts of B12, I can do anything I want. Unless this girl's vitamin D was 60 instead of 13, she was going to keep getting infections.
Right.
Until somebody biopsies her tonsils and finds out if they are the locus of infection for her recurring cellulitis, I can do anything I want. And FSM is not going to be able to fix it. So it's just, that was my week, was
We have very different weeks, but we both described the exact same thing about finding the driver is going to be the most important thing. And then knowing your limitations of what to expect, right?
yeah.
I know this triathlete is going to tear and break the tissues when they compete in a week. That is what I know. My job, my role during that in between period is getting the tissue as happy and their nervous system as confident as
Yeah. When you treat athletes, this is back when I was doing all my athlete stuff, our job is to fix them so they can go out and break it again.
yeah.
That's duh. Yeah.
Right. And to convince the nervous system that it is safe and it is okay and they're going to be just fine.
Mm-hmm.
Because, like you said, the injuries that we typically get are not from the source that we complain about the pain from, right? My left hip was bothering me last year in Kona. We found out my left SI was bothering me. It had nothing to do with my left SI. It had everything to do with my ribs on the right. Blah 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 blah.
Yep.
Things change. We have a very interesting question that I feel like we're going to talk about for a little while. So I want to get there for a second. Denise asks, I've met several families lately who all have fibromyalgia. Some have backs involved and some don't. Is fibromyalgia a genetic condition? If so, does the protocol we still have a chance to work for them? I'm taking a deep breath because of words.
Oh, it's okay. The fibromyalgia from spine trauma amounts to about 27% in the literature and 40% in my personal experience. There is a genetic type of fibromyalgia where there is a genetic defect in either the dopamine pathways or the serotonin pathways, or running in families. The other thing that runs in families is food sensitivities. So the whole family can be celiac and not think of it as being celiac. So they're eating wheat, which gives them leaky gut, which gives them macrophage mediated pain, which gives them fibromyalgia. The other type of fibromyalgia is like the one with organic chemicals. Where are they raised? Do they all live in the same area? Or is this family spread out all over the United States and 3 foreign countries, and they all have fibromyalgia? That, can it be just the architecture that they inherit? Their palate and larynx is soft and floppy. Their necks are built a certain way. And everybody over the age of 17 has sleep apnea. Do they have a genetic alteration in the, usually it's Patrick's specialty was dopamine. Mine was serotonin and fibromyalgia from spine trauma. Food sensitivities, those are the ones that can be genetic. So if you listen to the 8-hour fibromyalgia workshop, that has all 7 or 8 types, and that includes the genetic type. But even the genetic type, there are some of them that will have a genetic defect like they can't phosphorylate B6. So B6 can't compete with estrogen in the anti-inflammatory prostaglandin pathways. So if they can't phosphorylate B6, they can't get to this step. So they end up being inflamed, they end up being in pain. And once they're in pain, then fibromyalgia just tumbles down. So once your pain levels are above a 4, you can get fibromyalgia, but the gene that's involved is something you have to suss out. Are they sensitive to milk and gluten? Are probably the food sensitivities, IgG food sensitivities that run in families. There's dopamine SNPs, there's serotonin SNPs, there's methylation SNPs, and there's detoxification SNPs. And any of those genetic alterations that get in the way of any of those genetic alterations that create pain will create fibromyalgia, because once your pain is above a 5 or a 6, it becomes a neuroendocrine problem. So it's the pain starts first, and then the neuroendocrine system, growth hormone is suppressed centrally, TSH is suppressed centrally, and LH in females and males are suppressed centrally. So the males will have low sperm counts as well as body pain. And that's a whole 8-hour workshop, Denise. So I'm going to tell you, go back to that one. And there isn't the protocol. 40 and 10 won't work on these people because they're not from spine trauma, unless the whole family is Ehlers-Danlos. So if they have Ehlers-Danlos,
I was waiting for you to bring that up, and I'll let you keep talking, because, and the problem I have with any time I see or hear fibromyalgia, I ask them to tell me about how they were diagnosed. Oh, my doctor found 2 tender points on my back, and I have chronic fatigue, so this is what I have.
wow. And this is why we don't keep adult beverages in the clinic. It's like,
These are the people that come in because I prayed for patience. And so the universe is, you want patience? Here you go.
yeah.
I do know of a family, and they all are Ehlers-Danlos, and the 2 of them were diagnosed with fibro, and it had nothing to do with fibromyalgia. It was all Ehlers-Danlos and mast cell.
Ehlers-Danlos, mast cell, and the Ehlers-Danlos actually creates a 40 and 10 component because the discs leak and irritate the pain pathways. And then their vagus gets turned off, and then you get to the mast cell component, and it's just follow the bouncing ball.
Yeah.
That is the thing that makes the advanced so much fun.
Yes.
That it's the one place where everybody that you're sitting next to or in a room with has got this, we think differently.
Yeah.
I guess because I beat people over the head with it. It's go back to the cause. Yeah.
And I think, I'm no expert in this, but I think a lot of people do get caught up with labels and diagnoses. And we talked with Dr. Musnick when we were talking about autoimmune. Some people are just very like doom and gloom when they get a autoimmune diagnosis. And it's the opposite. It is something that can be so manageable, provided that you have the right practitioner that can keep asking the right questions and can create an environment within your body that supports suppression and healing.
David Musnick turned my autoimmune condition off as long as I don't get gluten. If I'm in a situation or in a country where I don't have any choice if I do this, I don't care, I'm going to do it anyway. So if I get gluten, the spasticity comes back. I knew it was going to. And in 3 days, I can get it gone again because I do what Dr. Musnick told me. And autoimmune conditions, you do have to clean up the peripheral tissue, but the basic process of creating an autoimmune condition is, once you know how to think about it, then fixing it is fix the vagus, figure out what turned off the vagus in the first place, what happened 1 to 3 months before the first symptom hit you, fix the gut, and then treat the periphery. It's not that hard. And is there anybody that ever says that except us?
No, and I don't even want to say it because like I am also worried about lightning and striking me as soon as I say that. I want to go back to fibro for a second. There used to be a criteria for the tender points for fibromyalgia diagnoses. You're making a bit of a face. Is that still relevant? Is that still what's being used? And are there any other tests that corroborate? No. Okay.
They got rid of it used to be 11 out of 18 tender points tender to less than 4 pounds per square inch pressure, non-restorative sleep, and non-restorative sleep, 11 out of 18 tender points, and I forget what the third criteria was. And then sometime around, had to be 2006 or 7, the American College of Rheumatology took out the tender point exam, and it left it with central sensitization, chronic non-restorative sleep, widely disseminated body pain, lasting more than 3 months. And the summer of 2010, American Academy of Pain Management was meeting in Seattle, and I had a chance to go visit with John Russell. And I went up, and John and I have an interesting relationship to begin with. And I said, can you tell me why you removed the only objective finding for a diagnosis of fibromyalgia? What on earth were you thinking, John? And he rolled his eyes and he looked not quite embarrassed, but his head, and he said, 25 years. We had that criteria for 25 years. And in 25 years, we could not teach them. If everybody that's watching takes their thumb and presses it on their index finger like this, and you press and look at your thumb nail, that's assuming you don't have polish on. You press, so your thumbnail is kind of pink if you're healthy and not hypoxic. Then you press, and when the thumbnail blanches at the bottom, it goes from pink to a little bit pale. That's 4 pounds. Now you can train yourself. We have a bunch of kitchen scales, so you can train yourself to what 4 pounds is. I said, John, he said, we couldn't teach them what 4 pounds felt like. I said, I have an algometer. You just measure it. He said, they wouldn't spend the $150. He said, what is the point of having a criteria that they won't use? I went, oh, okay. I still use it, but that's why it's not part of the criteria. So you can't have 2 tender spots on your back. You can't have fibromyalgia of the right shoulder. When I teach a class, one of the things that you start with is Robert Grimm, MD, neurologist, his voice in my ear saying, the first thing you do when they walk in the door is you ignore every diagnosis that they've ever had. You just start over.
Right.
So they walk in with the diagnosis of lymphedema and cellulitis. Okay, there's a reasonable cause for that, but so I didn't ignore, you can't ignore the fact that she had surgery and radiation and there's lymphedema. But lymphatic fluid is sterile. Did anybody ever talk to you about a reservoir of infection? No. Did anybody ever talk to you about trying to strengthen your immune system so you don't get sepsis?
Right.
No. Fibromyalgia is the same way. Patient came in with a diagnosis of fibromyalgia in the right shoulder. There is no such thing. Full body longer than 3 months. That's fibromyalgia.
Right.
And you can't help that it's not their specialty. You can't help that they're just, I have an autoimmune condition or have an autoimmune condition called stiff person syndrome. And the neurologist I saw after I had imaging that showed I didn't have MS, I didn't have ALS, and I didn't have spinal cord myelopathy, but I had spastic or tight, really tight lower leg and chest muscles. I swear to you, the neurologist said, maybe you have fibromyalgia. And I went, I don't have fibromyalgia. How
But
do you
thank
know? That part was really fun. So I actually sent him Leon Chetow's book, my syllabus, a bunch of other papers on fibromyalgia. And I sent him with a very polite note that says, you're one of the best neurologists I've ever seen, and nobody as good as you are should be this ignorant. Read the attached, and then you will know better. I only seem like a nice lady. It was just one of those things. Right.
you're right. Again, going back to if your training only enabled you to see very myopic set of symptoms, and it was just very easy to give that set of symptoms a label, and people are okay with that label, and it doesn't change how you treat that patient as far as prescription or whatever. Where's the motivation to change or to do anything? With us, it's everything. Tissue type is everything. Pathology and causation is everything.
What caused it? How?
How did it get like this?
Yeah. And
That's what I think all the time. Yes, the good old days, A and B. What's on A? What's on B? German Shepherd on my lap, right? But now it's okay. This on A is happening to this on B, but don't get caught up in that. How did it get like that? What happened?
And what else do you have to do to help the patient recover?
How can you
Our
support?
goal is, yeah, our goal is not just to run FSM. As far as I'm concerned, our goal is to change medicine one patient at a time.
Yeah.
And change patients' lives by helping them recover. And sometimes recovery is vitamin D and vitamin C and B12
And you don't have to be, you seem to be such an expert in so many of these different areas. A lot of us aren't, but that's when networking becomes so important. That's when making friends in different professions becomes so important. I can't do this. Can you see this person? What do you recommend for this? And I think true healthcare needs to be much more collaborative than what it is. What's the jack of all trades, master of none? I don't think that has any place in healthcare. I'm really good at mechanics. I stick to that. I ask for what I need it.
I just listen to information. Like Roger Billica gives a lecture. I read the molecules of behavior 3, 4, 6 times a year. I look over David Musnick's slides every time I do a core. Speaking of which, we have a core in December, a 5-day, and we have a 2-day practicum in November and a 2-day rehab class. And are you doing a sports advanced?
The day is there for it, and there's a couple people signed up. We're going to do it no matter what. So it's a short class. It's fun.
Okay, that'll be fun.
Yeah.
Think of that. And then we're going to be dark January and February, mostly because my clinic schedule, because I was gone so much this last year, my clinic schedule is solid all through January and February. I don't have any time to do a seminar. So then there's Arizona, and the advanced is, I don't know how many people are signed up for the advanced and symposium, but it is an extraordinary lineup. The case reports are from literally all over the world. Eduardo is coming. Kasia is coming from Poland. May is coming from Belgium. There are practitioners coming from all over and speakers coming. Jerry Pollack may or may not be speaking because his computer got stolen in Poland at the water conference and he didn't have it backed up. That's a good face.
Oh, that makes me feel ill.
Yeah, I cannot imagine. I don't know. So I may have a 90-minute slot that we get to fill with, but it's still the only place you feel normal. Because we ask questions that nobody else asks. We know things that we think things that nobody else thinks. We ask questions that nobody else asks.
Yeah.
We know random stuff. So people that are listening to this podcast, there should be about 30 to 40% of you that go into the bathroom, especially those of you that are vegetarians over the age of 40, go into the bathroom and stick your tongue out. It's what color is it? Does it have grooves? And then Dr. Google is fascinating. What causes atopic dermatitis? I thought leaky gut. It's all the immune system activation. Nope, that wasn't it. I can run vitality in the skin until my blue, but she sticks her tongue out. It's bright red and has grooves all over it. Oops. That's not a thing that FSM can fix.
And
So,
but you can support it in other ways. So it's not about just seeing a list of symptoms and signs and checking them off as you go along. It's learning how to connect the dots. You always talk about pattern recognition, putting it together, and then developing a plan and knowing where you can help support healing and where you need to ask for help and bring in other things. Like there's always something that you can do, provided that patient just walks in the door.
yeah. And when you said put things together, on this patient with the B12 in the skin, I treated leaky gut 4 days in a row. B12 has to be absorbed. In order for B12 to be absorbed, you have to have enough stomach acid. This lady was on steroids, oral and topical, for 25 years. Yeah, treated her leaky gut, but the gut has to be healthy enough to absorb B12. So she's taking it sublingually, so it's absorbed through her mouth, doesn't have to. She's not going to eat meat, so she's not going to get it that way. But the gut has to be healthy in order for the patient to be healthy.
Right.
So everything's connected to everything. I think that's going to be another banner, right?
I think at the very least, when you have complicated patients that walk in, to ask the basic questions about their digestion and about their sleep.
Mhm.
If you are not digesting your food and you are not sleeping at night, nothing matters. Nothing.
That's it.
We have to be able to digest our food. We have to be able to sleep at night.
Oh, and that was the other thing. The patient with the recurrent infections also had she had a tumor in her right inner ear. And so she had a vestibular injury. So she woke up every 60 to 90 minutes, explained about pillows and nightlights and meclizine and Valium and all of that in terms of getting her to sleep. I've been taking Ambien and I want to wean off of it. It's like, why? I shouldn't be taking pills to sleep. That's an interesting concept. On the other hand, if you don't take pills, do you sleep? No, then take pills because sleep is more important than your idea about what you should or should not do.
Right.
Don't get attached to your idea about things. That's an interesting concept.
That could be a whole podcast unto its own, is the attachment we have to the diagnosis, the attachment that we have to treatment. It's not easy, and you can't be everybody's friend. right? You have to have the
Mhm.
tough conversation sometimes.
Every now and then there is a come to Jesus conversation about something. It's, I know you're not going to eat meat, but you have to do this, or you have to be okay with being sick. There's
Right.
no way to get you better unless you do this. And if you're not going to do that, and whether that's wheat, corn, milk, whatever,
Visualization exercises.
yeah, exactly, then you can't have it both ways.
No, and like your job as the healthcare provider is to have those hard conversations, especially if it's blaring and glaring at you right in the face, right? The flame is there. You see the person putting their flame in the fire. My hand keeps getting burned. Don't put your hand in the fire. Just
Exactly.
stop
It
doing that.
hurts when I do that. Don't do that. That's a thought.
And of course, with athletes, my job is to help them move through everything as best as possible. But when like I said, the non-negotiables are digestion and sleep, because
Yep.
and that's only been years of experience of why isn't this person getting better? Okay, it's not my fault. I can't do everything in an hour and a half.
When you think of sleep as just what's a big deal about sleep, 85% of growth hormone is made during deep sleep. And if you're not getting deep sleep, then you're not getting growth hormone. And growth hormone in an adult mediates the transport of amino acids across the gut wall, across the cell wall to repair muscles.
Right.
That's why you're sleeping. You're not sleeping because I want you to sleep. You're sleeping because you need growth hormone.
The repair and heal is taking place during that deep restorative sleep. So the question of, so do you sleep well at night, is not the question that you ask. You ask them, what time do you go to sleep at? Fine. What time do you wake up at? Fine. How many times do you wake up in the night? Why do you wake up in the night? Is it to pee? Is it from pain? Is it because your partner is snoring? Do you snore? Do you sleep with the pet? This is a very long conversation, and Dr. Musnick is going to be talking about it at the advanced in for 3 hours. And I can't wait for it, because he tried to do it in 90 minutes a couple years ago. And I wanted to pass out because it was just like too fast, too much. And there was so much that we had missed.
It's one of the reasons I have the same speakers back over, and sometimes I'll skip a couple of years on a topic and then bring it back again. Giving him 3 hours, there's no reason anybody that has already taken the advanced section should listen to me for 3 hours. That's why you get 3 hours and Dr. Musnick gets 3 hours. And then I like people to understand the concepts of what we're doing, which is why Juliana Mortensen is back. And then the hot topic this year from everybody, Dr. Musnick is doing 90 minutes on long COVID. Christy Hughes is doing 90 minutes on long COVID. Becky Blodgett is doing 60 minutes on blood vessel health and sleep apnea. So her hot button is sleep apnea and what it does to the blood vessels. And then that ends up right back at sleep and long COVID and gut repair and repairing the blood vessels. And it's just
And then you go on the plane when you leave and you're like, I am going to fix the world. It is that inspirational.
yeah.
And just like that, an hour has gone.
Oh, look at that. There it is.
But thanks for letting me debrief about my menisci today.
Oh, it's a great way to think about it, because I had not thought about the difference in and the other thing is that it's not arteries, it's capillaries.
Yeah.
So it's capillaries in the meniscus. So you're treating bleeding in the capillaries, torn and broken in the capillaries, vitality in the capillaries. And that takes us back to why the case reports are so important. The case report slots are all full, but people are still sending in case reports. So we are going to have poster presentations all around the room. And
Amazing.
apparently this year we're having exhibitors, because there are two nutritional companies that the speakers, our visceral speakers want to have exhibits. That was on my list. It's going to be a good time. And I get to see you in 2 weeks. A week?
No, I'm coming Sunday.
Sunday. It's not even a week.
Yes.
Oh my God. Are you going to be in Portland on Wednesday? Are you going home on Tuesday?
Wednesday, and then we'll be able to, I'll do the sports advanced course, and then we'll do our podcast together.
In person. Oh, how fun.
Yes. So next week we will see everybody. We'll be side by side.
That'll be so much fun. Have a good week.
Yes. We'll see you soon.
See you soon. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.